Oh,
Psn and Pablo.
Pablo?
hello. How are you, Vladimir?
Hello. How are you doing, Pablo? You
I
haven't
just
spoken to
arrived at
each other.
home.
Yeah, I'm right at home, exactly. Because in hospital we have so strong firewalls that I don't get the connection. And it's better to do it from home.
Yes.
Yeah. Salman, shouldn't we have been just now in Pakistan?
Yes, we should have been as we speak. We should have. We would have today. We would be in Nanga Parbat base camp.
Next
So
year?
Yeah, next year we are planning. So our plan was to go on 26th and then do the Skardu thing and do the China border, and there are beautiful mountains there, so explore that. And then we would have been in Nanga Parbat, Ferry Meadows yesterday, day before, and Nanga Parbat today, and probably going back tomorrow. That was the plan, but maybe next year.
Sitting at home. Next year, the same date. Pablo, will you join us?
Of course.
Sure, you must.
And indeed, Salman promised me.
Good.
Definitely. And Hassan Syed is going to also come along. Hassan, are you there?
Yes, thank you. I would love to.
That's going to be brilliant. I think we are nearly there. Hassan, you want to start? I haven't seen Shabir come in, Imad. So Shabir is one of our professors who was supposed to join. He was trying to check in, but he was saying he was having difficulty with Zoom. So let's see. So let's start. Yes, Hassan, please.
Sure. So first of all, thank you for having me to moderate. I wanted to introduce our first speaker, Professor Benez. As we all know, he's chair of neurosurgery at the First Medical School at Charles University in Prague, in Czech Republic. He's a very distinguished has a very distinguished clinical and academic career. He's been the principal investigator or co-investigator of numerous international trials. I think he served in leadership roles in many organized neurosurgery groups and serves as a member of editorial boards of numerous journals as well. And so today he'll be speaking to us about aneurysm dissection techniques, and we're all very excited to hear about his experiences.
Okay, hello everyone, and thanks for the introduction. It's always something which probably should be kept for later, because then one is not that ashamed of being praised by someone. I'm going to talk on aneurysms today. It's a question of cooperation, competition, or fight between the two modalities, or what's right and what's wrong. So let's take a look on that. There are many coworkers who cooperated with me. Actually, the whole department. This guy over here is our chief neuroradiologist, who is doing almost all of the endovascular treatment we have, and he's by far the best in the country. Very experienced and very kind guy. And you will see from the very beginning that he's part of the team. So we do not consider him to be something else. He's in all our morning conferences. He's virtually living with us. Let's go a little bit to the history. This is my assistant professorship thesis from 1992. It has 250 pages, and since I'm always rather systematic and thorough, or used to be, not anymore, Pablo can confirm that, one page was devoted to endovascular techniques. Only one page, and only out of my curiosity and out of my willingness to have there everything. 1992. Within 10 years, endovascular techniques spread all over the world. And since 2000, it's routine for us. Actually, these techniques changed everything in neurosurgery, be it the gamma knife or be it endovascular techniques. We always think that new is better. That's not true always. We always think that endovascular is non-invasive, but you can do the same harm from without or from within. So it's not true either. But by now, our mentality has changed as surgeons. We must be brave to clip the aneurysm because there is an alternative. If you make a mistake or if you have some complications, always the first question would be, shouldn't the aneurysm have been treated by endovascular? So it's much more dangerous, the surgery, than 20 years ago. Those are not difficult surgeries, but still, at the time, before these techniques, we were like fighter pilots. We had a mission to fulfill. with no respect to collateral damage. By now, we must be airline pilots. Something's wrong, we must go back. So this is the mentality which has changed. What evidence do we have for aneurysm treatment? We have this only one large trial, the ISAT, the only international one. We participated in there at the end of that because it was rather difficult to enter the trial, but still, this is the only one we have. These are the results of the trial 50 years after the conclusion. You see that both endovascular and surgical results are running parallel. But from the very beginning until year 11, 12, the endovascular treatment was better. And this was statistically significant. See in which percentages we are talking about, what difference there is. But it is statistically significant. By now, it's even. And we can expect in future that surgical treatment will be better. I will explain later and throughout the whole my lecture why. So this is the evidence we are having. We then have this BRAT trial. Difference did not reach statistical significance, which was the only other randomized trial. What evidence? What is the evidence-based medicine? Just in short, it's not only the randomized trials, which are over here in the pyramid of evidence or of quality of evidence. It's something between the best evidence, those are the randomized trials, the clinical expertise and experience you are having, and the patient value. Only where these three meet, it's really evidence-based medicine. And all these evidence, randomized trials at best, are nothing better than the traffic signs. If you see this sign, it's internationally understood, everyone knows what we are talking about, but you must get there to realize whether at 40 kilometers per hour, you will either destroy your car or you would be hindering the whole traffic. This is actually just the suggestion by the police. Or like a maps. You know how to get from the point A to point B because maps are internationally understood, but you do not know what it looks like. You must get there to realize again what it really looks like. So this is the evidence we are having for aneurysms. It's not much. Some 10 years ago, we wanted to know how we treat aneurysms in Europe. So we did an internet survey. The Europe by European Union standards is divided into the East, North, South, and West Europe. You see the countries. And these are the results we got. In the Eastern countries, the relation in ruptured aneurysm, the relation was 2:1 clip versus coil. As opposed to Northern countries, it was 1:2, just the opposite, but both were happy. No one complained. In unruptured aneurysm, it was 1:1 in Eastern Europe and 3:5 in Northern. So these were the major differences in European countries, how we treated the aneurysms. But we really saw that we are treating them rather well, and no one was telling to the other, you should change your policy, you should have this relation or that relation. So we took a look on our results in the first 10 years of routinely having the endovascular treatment since 2000. 10 years, both modalities on a routine basis, 24/7. 2 surgeons, 2 endovascular neuroradiologists did it. So it was very coherent series. At that time, we have 1150 aneurysms. Relation was 70:30. And we are using deliberate policy that we, if I shall overdo it, we first treat the aneurysm and then we treat the patient. The patient comes in, we treat the aneurysm, and then we take a look on everything. The first step in all our endeavors was occluding the aneurysm. These are the teams we are having. This is the surgical team, this is the endovascular team, and of course we are friends. We treat them with compassion and camaraderie, and they are doing what we ask them to do. These are the results over the first 10 years. Exactly the same for both modalities. Be it unruptured, be it ruptured aneurysms, there is no difference whatsoever in our hands. This is the next decade. Again, no differences which would be worth mentioning and worth any statistics. So exactly the same we are getting. This is the graph which tells you how many years do you save or you lose with your complication rate. And this is a formula where it's the life expectancy of the given population. So this is the Czech population which is your complication rate. And these curves are for small and medium-sized aneurysms. And you see that again, both small and medium-sized cross the zero line at the same point, at the same age. The large and giant aneurysm, they never cross the zero line because the risks are too high of rupture. So again, no differences. What we looked at next about the quality of life after the treatment. We did something like 600 tests, and I can tell you that the tests were very exhaustive. It was a day-long testing. Many patients were exhausted. 160 patients. We had lots of publications out of that, and there was no differences in life satisfaction in all 23 domains. We didn't find any difference between clipped and coiled aneurysm, be it ruptured, be it unruptured, exactly the same. So both treatments in our hands were exactly the same. When you talk to endovascular people, they always tell you that they have some new device just behind the corner. Holy Grail is really just to be expected. If somehow you are able to prove that in some aspects of aneurysms surgery is better, they tell you, all right, it's now, but next week, next year, next month, we shall have another device. And again, this is the new is better. Read surgery is obsolete. That's the implication of these techniques. Is there really nothing new in neurosurgery for aneurysm treatment? We must be better to survive. If we wouldn't be better or good enough, we wouldn't survive. No one would go for aneurysm surgery. No problem to show that there is something new. It's minimal invasivity. In my mind, minimal invasivity is not about the approach, but about how you behave in relation to the lesion. So what you see here is the middle cerebral artery aneurysm after the clipping, and this is the whole cut in the arachnoid, 20 millimeters, nothing more. This is minimal invasivity. The craniotomy, how big it is, it's not important in my mind. What it looks like in real life, shall it play? Right, you see, this is the only opening of the arachnoid. Here we are on the aneurysm. And once you are there, you just dissect it the same way as in any other aneurysm. This very wide dissection. First, you get the feeding artery. This is the terminal M2. Here, the aneurysm sac. And you just dissect it, and then you clip it. It's not nothing that different, but still really only 20 millimeters opening. You can use whatever sharp or blunt dissection, what you prefer. It's exactly the same. But what's important that you do not harm the rest of the brain. The brain remains untouched, only in the vicinity of the aneurysm it is. Okay, I believe you got the gist of it. So let's go forward. The same applies to large aneurysm. This is the large terminal M1 middle cerebral artery aneurysms. And you see what we have learned. We have learned the temporary clipping. So this is the distal M1 segment, which is now being clipped along with the perforators, which is always a little tricky. And the one doesn't like to do that, but still in certain instances you need it because you want to decompress the aneurysm. This is the one M2 segment. Actually, this is not M2. You will see later that this is actually already M3. This is the temporal M2 segment. We used even bypass. You will see it later. And you just exclude the aneurysm from the circulation. Then you puncture it and decompress it. And then you can treat the aneurysm as you wish. You see, this is the puncture of the aneurysm and decompression of the sac. Let's go forward. And this is after the clipping. In these huge aneurysms and the MCA, you always need to leave a piece of the neck. It's almost impossible to extrude it completely because here are the perforators. And actually here is the another M3 segment. And this M2, which is in between these two vessels, had to be left behind because so the aneurysm was arising from the whole M2 segment. You see now it's being clipped by multiple clips. Here the perforators are very nicely preserved, which is the most important part usually. And what we are having here is the bypass. Let's move there. I hope that it will soon be seen. So this is probably new. Again, the whole Sylvian fissure is not open. Only the short opening of the Sylvian fissure here is the bypass to be sure on temporal branch, not on the frontal. We didn't do that at the time. And this is what we didn't have 20 years ago. This is the ICG, which immediately tells you whether you did a good job or not. It shows you any stenosis, any kinks or whatever. You can see all the perforators over there. As soon as seen here the bypass again, you see that it works well. So we are very satisfied with that. These are the perforators which are preserved. And another trick which we didn't have, that is the intra-OMR and the fusion, which immediately shows you there is no any ischemia. And this is the angio, which shows that there is a remaining of the neck. This is the post angio, this is the remaining neck. And you see the temporal branch is filled by the bypass, the frontal branch is preserved. So the patient is doing well. So this is probably new, you don't know how to do some 25 years ago. In conclusion of this part, the results are not typical. They are in like honest reports, but they are not bad either. They are honest. We are happy with them, and we think that what's most important is that the results are balanced. Exactly the same for both modalities. So we can conclude in here that the ratio 2:1 in favor of coiling seems reasonable. What happened when we introduced coiling? You see that the number of aneurysms being clipped in my department since its beginning, since late 50s, 60s, is remaining the same, some 40 cases per year. In the year 2000, we introduced endovascular, those are the red bars, and you see that suddenly we tripled the number of aneurysms being treated, because we are treating older patients, we are treating aneurysms which otherwise we wouldn't treat. So what in my mind is most important, that you are able to treat more patients with their aneurysms which otherwise would either be too risky or too difficult to treat. And actually, I don't mind whether this basilar tip aneurysm is being coiled or being clipped. What's important that the aneurysm is not anymore there, so the patient is protected and the patient is without any symptoms. This is important, not the modality you choose. The final result is really important. The same case, one aneurysm which is being coiled, very similar aneurysm being clipped. So whatever preference one is having is okay. This ACOM aneurysm, I wouldn't like to operate because you would be having difficulties to preserve the parent arteries being coiled. The same for this large ophthalmic aneurysm. It's rather easy to coil, but similarly, it's nice to clip this aneurysm. So it's really, the decision depends on many factors which are not relevant to any randomized control trial. You see what we are able to dissect rather easily. Basilar tip, the opposite side PCOM, the opposite side P1, ipsilateral P1. This is the PCOM, this is the carotid artery, middle cerebral, you get to its bifurcation easily. You get to the ACOM region without any difficulty from one single pterional approach like this. And you can dissect everything here. It's little enlarged. This is the opposite side set nerve, ipsilateral set nerve, basilar bifurcation, superior cerebral artery. So all these are readily accessible, readily seen. Actually, endovascular is perfect for aneurysms like this, because I believe that this would be rather difficult to clip surgically, or this intracavernous aneurysm, which I don't think are surgical diseases. It's much better to coil them or treat them endovascularly. Otherwise, you would probably need some bypasses and you would use some deconstructive technique, not reconstructive, which always is preferable. When we finished with this thinking, we took a look on repeated intervention in our series, and suddenly things were a little different. This is the whole series of 1,400 aneurysms, 860 endovascular, 500 surgical treatments. The redo surgery, some retreatment of the aneurysm was needed in 2.6% of surgical series, but 12.8% of endovascular series. And this is statistically highly significant, the difference. Even more in large and giant aneurysms, you see that it was 7% versus 25%. This means that 1 out of 4 patients need some retreatment in endovascular series. What were the reasons for these redo procedures? In surgical part, it was incomplete aneurysm occlusion, let's say technical failure. Neurosurgeon's decision, that was my decision in 4 cases that I saw that it would be too risky and too tricky to clip the aneurysm. So I was not ashamed to say, all right, I'm unable to do that safely. Let's quit. And directly from the OR, we went for endovascular procedure because our angiolink is 15 meters far from the OR. So this was my decision. And then in 2 cases, rupture during the craniotomy. That's the airline pilot thinking. Something's wrong, let's go down. So we quit the procedure. So these are important, and this is the part we can improve. Here is the example. This is done by my colleague. I can say that he was young at the time, so I don't blame him. He left behind part of the aneurysm, which was later coiled. This is my case. I have a rule that I always want to see the tip of the branch of the clip, because then I know that the aneurysm is well clipped and the whole neck is in. In this case, I was unable to get to the end of the clips. So I said, all right, I don't feel comfortable. Let's go to angio immediately. And this is the angio 20 minutes after surgery. You see that the aneurysm is still filling. I guess that it would be spontaneously occluded within a day, but still we coiled the remnant of the aneurysm. So this is the surgeon's decision when not to go. What were the reasons of endovascular retreatment in 111 cases at the time? This is something like a planned procedure in 1/3 of the patients. That the patient came in a bad condition during the night, so we just introduced the coil and then we put other coils to treat the aneurysm permanently. So this is more or less like intentional staged procedure. Then the typical thing is regrowth of the aneurysm after the subtotal or total or so-called total occlusion. This was the most frequent, and this is what we all are fighting with. And then there was the failure of the procedure because not everything is easy to be done, or not everything is possible to be done. So we repeated endo in 10 cases, and in another 20 cases where we were unable to treat the aneurysm endovascular, we switched to surgery. Here are the examples. You see the hand has 4 ACOM aneurysm. This is the first like stage procedure. First, this clip to prevent the bleeding or early rebleeding was introduced, and the next day the coiling was completed. Another case like that, first the stent was introduced, was hand has 1 patient. The aneurysm after the stenting nicely reformed, and we were able to coil it rather easily. This is one of the unruptured bifurcation aneurysms. Again, this was the younger neurologist who overlooked that this is not a loop, but that is the part of the aneurysm, so it was coiled in the other session. This is the typical basilar tip aneurysm, and we all know that it looks nice after the first coiling procedure, and this is what it looks like in several months, and the repeated procedure is needed. And even now, one doesn't feel secure, especially in these basilar tip aneurysms. ACOM unruptured aneurysm, you see we coiled it, it regrew, so we needed to introduce some stents and then another coils to treat the aneurysm permanently. And finally, this is something which I wouldn't dare operating. This is the dissecting aneurysm of the basilar artery. It ruptured during the procedure. Fortunately, our neurologist is lucky, so this is not the subpulmonary bleeding. This is the contrast media. The patient was doing well, so we coiled the aneurysm again. We recoiled the aneurysm. It regrew. We recoiled it. There are several stents there. and it's still growing. Finally, we produce this infarction in the occipital lobe with resulting homonymous hemianopia. And now the patient, some 15 years after the treatment, is still having the aneurysm, is still having the remnant there, but fortunately, she's doing well after 7 procedures. And after some 17 years, she's having only this homonymous hemianopia, which she doesn't care that much about. Another one from the beginning of our series, this aneurysm ruptured and we were able to coil it, but since we were not enough experience at the time, we were unable to coil this aneurysm, so it was clipped with the use of endoscope. You see the nice result in 2000. Then she came in a year ago with regrowth of the aneurysm. There was a big discussion between neurosurgeons and between our neurology people because we blamed each other that that was his aneurysm which regrew. Here it's apparent that what regrew was the coiled aneurysm, and this is the final result after the coiling. Another funny case, small aneurysm which are not really that suitable for coiling is being coiled. Then the coil migrated to the distal anterior cerebral artery and the aneurysm reappeared. It was recoiled, and since then the patient is doing well. So these were the reasons and few examples. These were the aneurysms we were doing past. I wouldn't dare offering surgery to such a patient anymore. I did it 20 years ago or 25 years ago with good result, but now I wouldn't feel comfortable doing such a case because this is a really difficult surgery and risky surgery. And for endovascular people, this is definitely excellent locality for their endeavor. On the other hand, pica aneurysms, like with this patient with Glasgow, 5 and major bleeding in the posterior fossa, and this pica aneurysm, it's in my mind surgical case, and we do them whenever they come in with recent bleeding. This is after surgery when you not only clip the aneurysm, but you decrease the pressure on the brain by removing some of the blood clot from the posterior fossa. You clear the fourth ventricle, and it's good because whole the supratentorial brain is preserved and undamaged, and the patient recovers well, and this one did well. So these pica aneurysms, I believe, are good for surgery, and probably the only ones in the posterior fossa, apart from few basilar tip aneurysm to preserve your experience. Actually, the best is superior cerebral artery, because that's the artery you hit when you come from to the basilar tip bifurcation. What was the hemorrhage rate after the endovascular treatment in these redo patients? 7 patients ruptured. It means 6.3%, which is much higher than the rupture in aneurysms. ICUIA tells you that. So the risks are higher. No hemorrhage was seen after clipping, not a single one. The outcome of retreatment, it's not as good as in, again, as in unruptured aneurysms. And these aneurysms are virtually unruptured because you treat them months and even years after the first initial treatment. It was 9%. It's much higher than our usual 3% in unruptured aneurysm. So it's definitely some risk is carried by residual filling. And in our last control, if endovascular was followed by endovascular treatment, there were still some remnant in 47% of the patients. If surgery was followed by endovascular, some filling was seen in 50% of patients. If endovascular was followed by surgery, there was 0. These figures means that half of the patients are not protected sufficiently. All in all, there is 6.3% of our endo patients are not treated sufficient, but it's the whole series. Now we are talking only about retreatment. And this is not good, actually. I don't like it that much, but important part is that the patients are doing well. So retreatment, actually, initial insufficient aneurysm occlusion is the most important risk factor. And to find that the best modality in our hands now is 3D angio. You see all the residual filling parts. You really see if the aneurysm is treated completely and sufficiently. The risk factors for retreatment: large aneurysms, of course, and of course fusiform and dissecting aneurysms. In these, almost all patients needed some retreatment. But what's to be concluded is that endovascular treatment definitely carries the risk of rebleeding. It's not as with surgery, when in majority of cases you may promise the patient that you will never need to see him again, that you will never need to do anything again, that his aneurysm is treated and he's risk-free. And you also do not need to follow up him that closely if he's surgically treated. All these endovascularly treated needed to have really sharp follow-ups for at least 5 years. If it's stable for 5 years, then you may prolong the follow-ups. But anyway, I believe that these patients need lifelong follow-ups. Technical effectivity: almost half of repeatedly endovascularly treated aneurysms showed some signs of residual filling. This is probably not clinically that significant, but definitely it's good to tell the patients. The technical superiority of surgery is obvious, and it's good advising your patient that you may tell him that surgery definitely is more precise and more definite and more stable. Take a look on this ophthalmic aneurysm. Stopped. Oh. It's easy surgery. The first thing you see is the aneurysm. You dissect the arachnoid, you dissect the carotid, which is behind the clip. Here you see the optic nerve, and you just occlude the aneurysm. I'm taking my time here because of the video. And then what Juha Hernesniemi is saying, you kill the aneurysm. You can coagulate it, then you check the clip if it's properly positioned. It is. Here is the carotid artery, and you may promise the patient that he will never ever have a recurrence at this point and at this place. You can never promise it to him with endovascularly treated aneurysm. The next advantage of surgery is one single approach for multiple aneurysm on both sides. You see those were both middle cerebrals and another few on the way, all of them treated at once. I don't think that this could be done by endovascular procedure. There would have to be at least 2 procedures with endovascular treatment. So how do we think about it now? The more subchoroidal blood we see on CT, the more we go for endo, because it's not possible to tell the patient that the surgery is harmless. And definitely surgery is another hit for the brain, which already is being hit by the subchoroidal bleeding. 2 hits at once, it's no good. So the more blood, the more endo we go. The worse the WFNS score, the more we go for endo. The worse the patients, the more we consider endovascular treatment. The older the patient, again, more we go for endovascular. The more midline aneurysm, the more endo. ACOM aneurysms are not that easy to operate, unlike middle cerebral or PCOM. So in these, we go more for surgery. In the midline aneurysm, like basilar artery and ACOM, it's nicely, they are nicely treated by endovascular. And the more medium-sized aneurysm, the more we go for endo. The really small aneurysms below 4 millimeters, they are better treated by surgery. The large aneurysm, about 15 millimeters, they are better treated by surgery. So the more medium-sized aneurysm, the more we go for endo. But there are other aspects. We don't have any strict rules. It's case-by-case decision, and there always is a neurosurgeon and interventionalist. Always the 2 see the aneurysm and they decide jointly. But there are also logistical aspects which people do not talk about too much. You know, you have your surgical list for Monday, and Monday morning the aneurysm comes in. If you want to clip the aneurysm, you will destroy the whole program for the whole day and probably for the whole week. So it's much more easier to tell the guys from neurology, okay, do it, please. We don't talk about it much, but it's definitely the aspect which needs to be taken into account. The same is financial aspects in some countries. If you clip the aneurysms, you spend something like 50 US on a clip. If you coil the aneurysm and use the stent, you may spend something like 15,000 US. So the financial aspects are important as well. And of course, experience aspects. There are many places where the endovascular people are more experienced than the surgeons. Exactly, the whole country is an example. It's France, where neurosurgeons do not the aneurysms almost not at all anymore. On the other hand, countries like even Czech Republic, we are still doing more in other departments, more surgically than endovascular. The chief neurologist in our hospital is part of the neurosurgical team, as I already have said. That's extremely important. What we have in our hospital is the Institute of Clinical Neurodisciplines. Everything which in hospital starts with neuro is the part of this institute, and the chair is neurosurgeon, and it really works. And all endo procedures go only via neurosurgical ward. Not a single endovascular procedure with target in a neural axis will go from some other bed, you know, like neurology or whatever. Only neurosurgical ward. The exception, of course, is stroke, but they treat only stroke then. We've published 2 articles which are rather nice. Coil mainly policy in ACOM and clip first policy in MCA. And that's exactly how we are thinking now. When there is the ACOM aneurysm, most likely it will be treated by endovascular. You see 315 cases, 240 by coil, and only 70 by clip. Just the opposite in middle cerebral. We do not discuss middle cerebrals too much. They immediately go for clip. You see 320 versus 80. So it's not a yes or no question. It is the quest for balance. The question is which technique is suitable for particular patient. You do not, you shouldn't be thinking much about evidence-based or about this or that. It's really each particular patient, case-by-case decisions. And I don't think that any randomized control trial can solve this question, because there are so many aspects which needed to be taken into account that randomized control trial will never be something like a detailed map. It will always be only a big, large-scale map. There are 2 guys in Europe. This is Jacques Moret, who never ever saw a brain but treated thousands of aneurysms. And this is Juha Hernesniemi, who never ever saw a single coil and treated thousands of aneurysms. These 2 guys had many discussions in many congresses. They could have swapped the roles and no one would recognize that. And they are both rather nice, but they are both too, let's say, dogmatic about their approach. I like Juha very much. He's a nice guy and he's a very good friend of mine. We've known each other since early 90s. And he's having his lectures. You all have heard that probably. And in some aspects he's right, but in many he's wrong. You probably have seen this image of Last Mohican, which probably Juha is considering himself. But this is completely wrong. This guy on this image is Uncas, son of Chingachgook, who is Mohican, both of them, of course. He's rather wild, responsible, but he gets killed in a fight with Magua. It's from this Fenimore Cooper book of Last Mohican, very romantic, and it was a famous movie. And this is Magua. It's Moret-like figure. He killed Uncas, and he was killed by Chingachgook. And actually, the Last Mohican is this guy. Is the father of Uncas, the father of the guy from Juha's image. He's intellectual, negotiator, tolerant. So he's the survivor. So if Juha was showing this Last Mohican image, this one should have been shown. So you see that not everything is really like you perceive it on the first sight. This is another favorite Juha's image, the Last Stand, the Spartans fighting the parts. Actually, they invaded Europe in ancient times, and they came even from Salman's place. Salman, you know that I guess Karachi was in the party, and wasn't it? But actually, what was it? It was Thermopyle, it was bravery, heroism. It's to be applauded. We all take it like a big piece of history, but it's a defeat. The Greeks lost in Thermopyle. They didn't stop the armies. They did it a year later at Salamis and Plataea. These two were the wins, not this one. So let's take it like that we are not looking on the first side, we are looking for the balance in the treatment of aneurysms. Thank you for your attention.
Thank you very much. That was a great talk. I really appreciate your insight into it, as well as some of the results of your papers. I'd encourage all the participants, if they have any questions, to please either raise your hand or to type your questions. Salman, I wanted to check to see if there was another speaker or not.
Yeah, we have Pablo, who's going to be sharing a case with us, but we can have discussion before this. Obviously, what we need is, Azam was supposed to be here today, but he had an aneurysm, an emergency aneurysm to do at this time. So he apologized, and he's going to try some other time. He's been joining us for all the webinars, but on his day, unfortunately, he's had emergency cases. So I was going to ask Vlad, for somebody who's not doing as many aneurysms, for example, the new guys at the moment, in our hospital, we are lucky that every aneurysm comes to us, and we decide what's going to happen to them. And every month, so we're operating about 6 to 8 aneurysm every month. So we are lucky from that aspect. But generally, in majority of the centers, they wouldn't have this kind of a workload. So what about those people, their experience and how their technical skill? Do you think that still remains, and do you think they're going to give the results that you are giving to us?
Yeah. Salman, I believe that this is probably the most important point which you have hit, that in few years' time, there will hardly be a surgeon able to clip the aneurysm, because the experience will be decreasing and decreasing. This is happening in Europe. In Europe, we have so many departments everywhere and only certain number of aneurysms. So unless you really are active in that, you will lose your experience. And especially for large and giant aneurysms, which are difficult surgeries, not the small ones, not the middle cerebrals or PCOM or even ophthalmic aneurysms. They are not that difficult surgically. You can land that. But for the large ones, which are difficult to treat endovascularly, we shall hardly have surgeons in near future here in Europe. So that's exactly the problem, how to think about the education, how to raise neurosurgeons who will be able to clip the aneurysms. It's not only the clipping, it's bypass techniques and all these surgical possibilities which are really needed in surgery. And to get the experience takes some time. It's not like with coiling. You can learn how to coil the aneurysm, I wouldn't say within 2 days, but within a month. But to learn to clip the aneurysm, it really takes time.
Okay, the other question, if I may, Hassan.
Yes, sure.
Yeah, is that what is your basic technique difference between a larger size aneurysm and a smaller size aneurysm? Is there any basic technique difference? What are you thinking when you're operating on a bigger size aneurysm versus a smaller size aneurysm?
Well, actually, the technique is basically the same. Basically, you need first to get the parent artery, and as soon as you have the parent artery, you are home free, because you can use temporary clips. In all the large aneurysms, we try to keep a superficial temporal artery for possible bypass. We do not cut it. We always consider the possibility of the bypass, but we first, before bypass, try to occlude the aneurysm. this is just opposite to the case I have shown where we did the bypass first. And I think that what you need to learn is to dissect the neck of the aneurysm, not the whole dome. You do not need to see the whole dome. You need to see the neck. You need to know what it really looks like, and then just dissecting the whole aneurysm is not really necessary. Actually, aneurysms in a way are much easier than skull-based meningiomas or whatever, because the anatomical situation is given. Nothing is pushed, nothing is split on the surface on aneurysm, nothing is, everything is where it should be, as in the textbooks, which is nice about the aneurysms. And I don't know if I can tell that, but if the regular aneurysm takes longer than, let's say, 20 minutes intradurally, something is wrong. It's a little overdone, but I believe there is something to that. So technically speaking, there's nothing that particular except for going for the parent artery first. Like for ACOM, you know, I find the ipsilateral A1 first, then I undergo the whole ACOM complex to the opposite side, find the other A1 segment, and only then go for ACOM complex. The same with basilar tip artery or superior cerebral artery. First below to the basilar artery stem, and then. In ophthalmic aneurysms, what I want to have is a balloon in the carotid artery before I start the dissecting. So these are, the parent artery is the must, and then it's like, you know, big studies of angiography. I don't think that it's that important. What you need to know is just a simple fact, is there an aneurysm or not? Because then you need to dissect the neck and you need to decide what to do. And some of the M1s, you know, I use multiple clips and I change them, and I use coagulation, whatever, just to model the neck. Some of them are, I wouldn't say difficult, but you need to think about it and you need to find the best way. And sometimes it takes 15, 20 minutes even after the dissection. It's not like our father did it, that they put the clip and they were happy with that.
And the technique to stop having a rupture, how do you make sure that you don't have a rupture? And if you do, what do you do?
That's exactly what I said at the beginning. If you have the parent artery, you do not care about the rupture much, because you just put the temporary clips and you just go on. You know, so the only rupture which is a dangerous rupture is the rupture before you have the parent arteries, but it's not that common. You know, I can tell you that in the past 10 years, I haven't seen one intra-op rupture before the parent's artery were dissected. That probably I'm lucky, I don't know. But in the past, before I knew how to handle the vessels and how to handle everything, I saw few, and really these ruptures before the parent artery dissection, then it's a problem. But if you would remember the history, it was Norlén in Sweden. He operated the aneurysm in a way that he ruptured the aneurysm intentionally, then he sucked the aneurysm into the high flow sucker. He dissected everything from the aneurysm and put the clip. But it was 60 years ago. I don't think that anyone would do it now, such an intentional rupture. But as soon as you have parent artery eruption, doesn't make any difference.
So I just also wanted to make a comment and ask some questions that some of the audience have posed as well. You know, Usman, you mentioned the number of aneurysm cases that you see at your hospital, which I think is great. Just for comparison's sake, you know, it's interesting to just see the number and the volume in various countries. So in the US, the Residency Review Committee sets case minimums for vascular lesions. And so in 2015, the minimum amount of vascular cases that a resident had to do in order to graduate was 50. 30 of them being aneurysm clippings. And the average at that time for a chief resident graduating was only 30 aneurysms, as a case minimum for clip. That, as the trend changed to more towards endovascular treatment options, I think those numbers even decreased. So in 2018, the residency review committee set a no minimum and just said, just report the numbers that you do. So I think it emphasizes Professor Benez's point that it's really important to take on these cases during training and be involved. But certainly this is also why a lot of the people who want to go into cerebrovascular neurosurgery end up doing fellowships as well. So just wanted to make that comment. And then one of the questions before we get too ahead was from Ali Ahmed. He asked, in case of more blood, isn't it better to go for surgery as it helps remove clots? If you could comment on your experience with that, that'd be great.
That's truly something which about the education in US, probably the residents are doing more than in Europe. In Europe, there are lots of residents who are done with their residency and they never ever did an aneurysm. And even the young residents I see it with my residents that they are not really that eager to clip the aneurysm, because they know that they will do it once or twice, and then again there will be some frog on the spring, as we say in Czech. Mm-hmm. And the next question you hit, it's something I still am not sure about. It's the amount of blood in the cerebral systems. By all means, if you clip such an aneurysm, you clean the systems. You may open the lamina terminalis, which someone is doing routinely, and you may prevent some of the vasospasm. You may do what Ibcherian is calling cisternostomy, actually, and probably this is helpful to the patient. This must be balanced against the fact, which I have already said, that surgery is by all means another hit to the brain, which already is hit by suppressed bleeding. So to balance this, it's pretty difficult. And if you would recall, in the past, when we started with acute surgeries in the 70s and 80s, we were talking about the angry and swollen brain. And if you did your clipping at the time properly, you cleaning the cisterns and eventually opening the lamina terminalis, your surgery were at the end like a normal slack brain. So you really helped probably. So it's really again the question of balance, whether the profit of this cisternostomy, let's call it like that, is higher than the danger of injuring the brain. Did I answer your question?
I think that was great. That was very helpful. Someone, is it okay to ask additional questions from the audience?
Yeah, I think we have a couple of questions. Let's do that, and then we'll get Pablo. I'm sure he's tired, but he keeps us entertained, so we'll wait for him.
Okay, great. The next question from one of the audience members was that, can you comment on your experience with blister aneurysms? Is it possible to clip them, and do you have any tips or tricks involved in that, as well as their diagnosis?
Blister aneurysm are a nightmare, because you may end up with a hole in the artery between the two temporary clips, and you cannot suture it, you cannot do anything. The only good point to them is that they usually are on the straight segment of carotid artery. And then you can use some wrapping and the window clip, or those special clips, I do not know the name, which are like covering the whole vessel wall. But otherwise, I really hate them. And they are almost unbeatable endovascularly, so you end up with surgeries, and one always must be prepared for deconstructive technique, it means sacrifice of the artery and bypass. Always prepared for that.
Thank you. And so the next question was from Mohammed Usman. His question was, what is the best time for clipping after rupture? I think that there's been trials related to this, and at earlier is better. But would you care to comment on that?
Yeah. That was the trial from I guess 80s. The joint the US was the principal country, and they said that the best time is like within 3 days. Then you should wait for another 7, and then you can do like a delay. I don't believe in this too much. As I said, we have this deliberate policy. I get that people from UCSF published a nice article about it 3 weeks ago. We really do it with no respect to time, with no respect to anything. And actually, we do not see that many of vasospasm as one would expect. It's somewhat not anymore that a big problem as it used to be some 30 years ago. 40 years ago, the main literature about aneurysm was amino epsilon caproic acid, or whatever you name it, against the rebleeding. Then we fought with hydrocephalus and difficult dissection. Later on, it was vasospasm, and we were studying nimodipine and all these things. Now, the main question in aneurysm is clip versus coil. What it will be in another 10 years, I don't know, whether it will be education or whatever. And I don't think that the vasospasms are that dangerous anymore, because we have endovascular techniques. We may do translumin PTAs and all these. We are using papaverine. We are having nimodipine. So we somehow know much better how to fight vasospasm. So if we are able to do that, then the question of timing of aneurysm treatment somehow is not that pressing anymore in my mind.
The next question, has to do with. Well, let me ask you: after you clip an aneurysm, do you ever do an intraop angiogram, or do you repeat an angiogram later on down the road? And with that, what's your experience with remnant aneurysms? Should they be operated on, sort of immediately, or is it okay to wait?
Which aneurysms? I didn't get you.
Sorry, remnant aneurysms.
Remnant.
Yes.
Okay. The angiography, intraop angiography, we do not use unless the case I have shown that we are going immediately from the OR to the angio. What we are using routinely is the ICG. I believe that it tells you all the info you need, and it tells it to you even better because it's dynamic and you can see from whichever angle you need to. But we routinely do post-op angio the next day, and we now routinely do 3D angio. In all the angio studies, we now calculate the 3D, and that's probably the best mode of treatment, most of diagnostics, and then you are able to tell the patient, all right, your aneurysm is really excluded from the circulation. So we have these two techniques how to check our surgical results. It means ICG and then angio. There was a time some 5-8 years ago when we didn't do angio routinely, because I somehow was, I was too sure of myself that I did a good job, that I said I don't need it. Then we started with this 3D, and suddenly I saw that that's not true, that there were some remnants. So now we are doing angio routinely, but we do not use intraop. I don't think we needed that much. And with the remnants, it's very, very individual. Most usually, the remnants are not really that big. And if it's something what is called dog ear, then we follow it. And only if it grows, then we go for reduced surgeries. surgery after the endovascular treatment, when there is a kilometers of coil inside the aneurysm, it's nothing that funny and nice and enjoyable, because the coils are then outside the vessel. I believe that you all have seen it. You dissect the aneurysm, but you are suddenly dissecting the pure coils which are outside the vessel, and then there are a few of them in the neck. You need to cut them, so it's more expensive because you need new micro scissors, and then you may even end up with a hole in the artery, which is difficult to treat. So it's surgically we treat aneurysms after the endovascular procedure only if they grow, and if we feel that repeated endovascular procedure is difficult, impossible, or not sufficient. So first we go for endovascular treatment after with aneurysm remnants. After surgery, in our case, we always went for endovascular treatment after with surgical remnants. So I cannot tell you what the redo surgery can be like, but from my early experience, you know, do I have time, Salman, to say some?
Yeah, sure. We will never stop you.
How I started with aneurysm, it was that I've been assisting my chief, lots of them. And at the time, I had a good memory, not anymore. And I remembered which were not really done properly from my point of view, what I saw. So when my boss retired, I called these patients back. And when there was the aneurysm, I offered surgery to the patient. There were something probably like 20, 25 of them out of probably 300. And until now, I believe that that was the best teaching for me. These redo surgeries after my boss, who by now is dead, so I can tell that, otherwise I wouldn't. And these were really good. And surprisingly, these redo surgeries after surgery were not that difficult. There was always good plane of dissection. There was always good dissection of the vessels, and even the clip was not hindering that much. So that's after surgery, I would offer patients surgery. After endovascular, I would offer him endovascular again.
Thank you. I know we're cutting close on time as well, so if it's okay, we should probably move to the next speaker.
Yeah, I think if we have time at the end, we can answer those two questions, or Vlad, if you like, you can answer them on the chat if possible, please.
Okay.
Great. So
thank you.
Vlad, that was wonderful. Really enjoyed that. I think it was an amazing experience, as always.
Thank you, Salman. Thank you. You are too kind.
Thank you, brother.
I think the next speaker is Dr. Pablo Gonzalez-Lopez, who we know well and has been involved in these seminars before, or these webinars, excuse me. He is a neurosurgeon from the University General Hospital of Alicante, Spain. I believe your specialty is skull-based, but other factors within neurosurgery as well. Teaching and education is a big part of what you do. And I know you've developed some training tools and 3D neuro trainers for educational purposes. We're very happy to have you, and I know you have some cases that you'd like to discuss. So thank you very much.
Thank you, Hassan, for the nice introduction. And again, thanks for inviting me. And Salman, I must apologize because it was a kind of last-minute preparation for these two cases. I'm not too much involved on vascular, and I was looking in my actually hard disks. I don't know if you can see them; they are here. I was looking for them while I was having a couple of cases that could be interesting. And I don't know if it's possible to have our colleagues to speak with me and to interact. Is that possible, or you prefer to go through them?
Yes, yeah? yes. You can ask questions. People can raise hands. We can unmute them. Hassan, you can do that. You know that. Yes, thank you.
Okay, so this is a case. It was Thursday evening in 2013, and this guy was playing soccer at 9 p.m. here in Alicante, and suddenly, without anyone touching him, he fell down, and he had no trauma. And the ambulance arrived there. He was GCS 9, and when he was admitted at the emergency room and had no pupillary changes, so he was intubated at that time, and this is how we found him. So this is what we saw in the CT scan, and I don't have any written question, but I would like someone to help me having a look at this CT scan, angio CT.
So if someone raise their hand, we can unmute you, and if you want to just describe what you see on the scan, that'd be great.
Okay.
All right. So let's see. Divi, do you want to introduce yourself?
Yes. Hello. Can you hear me, please?
Yes, we can.
Yes. Good evening, respected professors. I'm Dr. Sashank. I'm a young neurosurgeon, and also I'm more towards the endovascular part of it, being endovascular neurosurgeon actually. This scan in young male looks to be a ruptured a common aneurysm, as it is seen on the anti-intrahemispheric region, going upward from the gyrus rectus into the ventricle. Most commonly, it should be an common aneurysm, because in the young males, most of the times, the rupture in this particular region, especially, belongs to this ACOM territory.
Thank you so much. I'm sorry I couldn't prepare all the slides, but I can tell you that there was absolutely no subarachnoid hemorrhage in this case. But you are fully right. I fully agree with you. If I just show you these two pictures, that an ACOM rupture could be one of the possibilities due to its growing inside the parenchyma and also inside the ventricular system. But do you have any other possibility, any other thinking?
The other possibilities in young male, if at all it is not a ruptured thing, spontaneous loss of consciousness, there is a high possibility of vascular malformation, and that too especially in the base C frontal region. So there is a possibility of vascular malformation also to be ruled out apart from the aneurysm.
So you agree that a good
it
idea?
Needs angiography. It needs a diagnostic angiography. Because we cannot make sure with the CT angio, at least without a 3D. So
that's it. So before going there, the patient was ECS 9 and he was in the ICU. We were taking care of him. We decided to place an intracranial pressure monitor before going to the angio suite. And once we went there, the intracranial pressure was with the patient sedated. It was something like in between 14 and 16. And this is what we found in the angio. And as you have experience with that, do you want to keep going, trying to see what's there?
Yes, actually. Not sure about it, not see the pictures.
You cannot see them?
Okay, I cannot
Anybody
see
else
them clearly.
Wants to have a go? Anybody else wants to have a go at this? Please raise your hand. Shall we get Vlad to answer this?
Vladimir, can you help us? Is Vladimir there?
I think he's probably resting.
I'm here.
There's someone who's raising their hand.
I missed the question, Pablo.
And we were trying to have a look at this angio to see if we could identify some anatomical key landmarks to identify what's going on with this patient.
Well, I wouldn't call this aneurysm, Pablo. I would call it like a shunt or whatever. And localization. I don't see AP on my screen. Wait a minute. I'll try to put down all these figures. Frontobasal above the. No. I wouldn't give you close to the ventricle.
It's very close to the ventricle. Have a look at the. I don't know
Yeah,
if
I see it.
Yeah, if I go back to the CT scan, I don't know if you can see the pointer.
Yeah.
So I decided to put this picture because here we can see that the clot is directly coming from this area here.
From the area.
Yeah, which really corresponds with this. I guess this is, I'm not sure, you will correct me, this is a flow aneurysm. There was a small AVM, which was draining in a vein here. We will discuss this vein later on. And finally, this is drainage. So it was a small AVM close to the ventricular system, which this flow aneurysm, which indeed is what caused the bleeding in my mind, because the bleeding was pointing down from this aneurysm, small aneurysm.
Right.
So if we try to identify the anatomy of this malformation, let's call this malformation, we can see that the clot is very close to the frontal horn in the left side, quite close to the head of the caudate. So this aneurysm, flow aneurysm, is being fed by a branch, distal branch of the anterior cerebral artery. So whenever we want to decide what kind of treatment, it depends obviously of the endovascular team, and as Vladimir has been discussing, the experience we all have, the timing, it's also something important, but something very, very mandatory, even if you are going to go for endovascular or for surgical procedures, open procedures, is to try to identify and understand what's going on. So this was my exercise during I was on call that night, I was there. I was seated while the endovascular team, who are wonderful in our hospital, we are very lucky to have them. They were trying to go with a micro catheter inside this very, very, very thin branch in order to try to stop that, to exclude that aneurysm. So that branch was coming directly from the bifurcation in between the pericallosal and the callosomarginal in the left side. So if you see this anatomy here, this is the A1, A2, this is the pericallosal, and at the level of the bifurcation of the pericallosal and callosomarginal, a very, very small branch is going inside the cingulate gyrus, and it's going all the way towards the caudate nucleus in the just lateral to the frontal horn. So that was what I identified in this case. And our radiologists were trying to embolize it, but I was praying they could do that, but they couldn't. They couldn't go inside that small branch. I don't know if you have experience with this kind of small feeders. If you have another opinion, you think it could be managed endovascularly in this case. Do you? Vladimir, your opinion?
Yeah, I can't. My speaker doesn't work.
Oh, I'm sorry. No worries.
So now probably do you hear me now?
Yes.
Yeah. This is the case of the AVM, which I hate doing. You know, once there is a bleeding, you always have a problem to get a good orientation. You see the bloody brain, and you really are resecting the AVM only by your feelings, not much of it by your. You can do that because you are excellent anatomist. But
well, you can imagine if you are thinking that, you can imagine it was my second year as a specialist in this city, so you can imagine how I was feeling about it. But the thing is that it was night. It was night time. He came at 11 p.m. to the hospital, and the radiologist decided not to keep going at 4 a.m. 4 a.m. So I waited until 7 a.m. till the nursing team of our scheduled OR arrived. So we had the intracranial pressure monitor was okay. So he was in between 14, 16, 17, no more than that. And once we had everything in our OR, we decided to do surgery in this case. And as you said, we were discussing about going transcortical through the frontal lobe, or trying to identify these branches. And this is what I finally decided in order to gain a good orientation and to try to identify the flow aneurysm, which was the real problem. So my idea was to go quite anterior in the interhemispheric space, try to identify this pericallosal artery and the callosomarginal bifurcation around this area here. And if we were lucky, we could even see this small branch, which was going inside the cingulate gyrus. That was the feeder. If we could identify that small branch, surgery is completely over. So let me show you, this is the left frontal lobe. You can see how damaged it was. So we were trying, well, it's this kind of semi-lateral position I like for interhemispheric approaches, especially in these cases in which you need quite good maneuverability. So that's the folds, the depth. And the idea was, before removing the clot, to try to identify this anatomy. So that was what I was trying. So that's the contralateral callosomarginal and ipsilateral callosomarginal. So we are getting close to that point. We wanted to see the bifurcation between the pericallosal and callosomarginal. So once we were there, that's the contralateral cingulate gyrus. So this is the ipsilateral cingulate gyrus behind the cottonoid. This is the some attachments in between both callosomarginal. And then at that point, I saw the bifurcation. This is the callosomarginal going up. And that's the pericallosal. So at that point, I did a corticotomy, and I was extremely lucky to, after removing a little bit the clot, to find this small vessel. That's the cause, and that's the main feeder of this flow aneurysm. So that was under control. I was quite safe at that time. So once we removed the clot, we found this flow aneurysm. It was partially thrombosed at that moment. So a small clip in the feeding artery. So I was quite safe at that time, but I was thinking that maybe the AVM could have some other feeders, maybe some distal lenticular striate somehow. But the main feeder was cut at that point. So I just followed the flow aneurysm, looking for the small AVM. So I just wanted to take it out. And then moving distally, this AVM was draining in the striate, thalamus striate vein, and going to the internal cerebral vein. So we can see this is the flow aneurysm, and that's the artery in between the flow aneurysm and the small AVM. So this is like meningioma surgery at this moment, just trying to surround and devascularize completely this small AVM. There were some small feeders, as you can see. And finally, I wanted to find a draining vein, which was going inside the ventricle. This was the architecture of this AVM. So it was there. And we excluded that one. And I placed some glue. So I don't know if we could understand this kind of anatomy, but this is what I draw. I like to do these drawings after surgery when I have a plan in my mind, and if it fits or it does not fit, I like to draw them. So this is the anatomy I wanted to find, and finally I did. So this is the pericallosal. So this is the small feeder we found. We closed it here. So this was a rupture, flow aneurysm, and a small AVM, which was draining into the ventricular system. So we were lucky to find all this stuff. So this is the post-op, and the patient did quite well. It was 7 years ago, and he's still having a minor deficit. He has some spasticity problem distally in his right leg, but otherwise he's doing an almost normal life with this small AVM. And luckily, there was no other feeder which was hidden or obscured by the bleeding. And this is something I would like to ask. Vladimir, can you hear me?
I can hear you. It's Pablo, this is an excellent case, and this only shows how important the anatomy and understanding the anatomy is. This is more or less underscores how good you are at these things. You know, this is something which is probably important for young people in the audience, that you really need to think about it. You know, you should know how to do that, where to go, what you are looking for, and finally find it. And especially in this distorted and recently bled patient, it's excellent, excellent.
That was the question. How common it is to find in these small AVMs to find different feeders from different systems? Because I was a little bit worried about having some depth arteries feeding this AVM coming from lenticular striate, also
Definitely.
from the line, or I don't know how
there must be. I have never ever seen an AVM with a single feeder only. You must be looking for them actively. That was excellent. I would just suck it out, you know, and resect it, the whole part of frontal lobe, probably. I have seen several of these AVMs like that with the aneurysm. I have shown one probably in one of our courses, but I always did them in a cold phase, never recently bled. It's too difficult for orientation and too obscured by the recent bleeding, everything. This is an excellent case.
Thank you, Vladimir.
Pablo, wonderful case. Really enjoyed that. Hassan had to go because he has a clinic now, so he's going to go into his clinic. We have Chandrasekhar Devpujari and we have Victor joining us. So I think we have two more moderators joining us. So I think we'll get them to look after you from here onwards. But you can show your next case. It's brilliant. Really enjoyed that.
Okay. Then the next one, are you sure you want me to keep going for the next one? Do we have time?
Yes, I will.
Can I ask one question to Pablo before he goes for the next case?
Sure. You are the moderator, Chandra.
No, Pablo, nice case. I'm just wondering, it is, you know, like localizing a DACA aneurysm. And one of the key features is to know if it is, you know, where it is located in terms of genu. And do you have any calculation for that as to should you come from the top or should you come from the front? And how would you sort of in front to back direction, how can you be more sure as to where you are going?
So as you saw, well, in this specific case, I did a very big craniotomy because I was expecting to have some brain swelling. So in these cases in which you have a huge panoramic view of the interhemispheric fissure, you can choose where to go through. And even if you do a small craniotomy, and you will probably correct me, you can just turn your microscope looking for the whole extension of the anterior half of the corpus callosum. So even if you, due to the breaching veins, for instance, you cannot go parallel or perpendicular to your target, you can go anteriorly or posteriorly and just turn a little bit the microscope so you can gain a good orientation. But in this anterior side, something very interesting for me is to find or to try to localize the bifurcation in between the pericallosal and the callosum marginal. That helps you a lot. And if you have in mind the topography of these two arteries related to the aneurysm or to even the tumor you are going to face, that could be very helpful. I don't do measurements with rubber so deep. I just look for an
with your mastery in anatomy, probably it is not, you have a good instinct. But what I would say to younger audience is probably using a navigation in such a situation may be a good idea. And I use a navigation with a CT angio if I'm operating in this area.
Yeah, I always do that as well. I think it works very well there. You know, you're then confident, but Pablo, with your anatomy, I think you're very good. So you're able to
I really agree with that also. I really agree with that.
Yeah. Pablo.
Thanks. Great case. Yes, Vlad.
Yeah. Pablo, do I understand properly that the main landmark was the ACA division?
Well, yes, the bifurcation.
You were going interhemispheric, looking for the division. Callosum marginalis, pericallosum, and then when.
Yes,
yeah.
in this specific case.
Is important because This depicts your train of thought, which is probably it's excellent. As Chandrasekhar has said, that the knowledge of anatomy.
I don't know if you can see, Vladimir, in this cut, in this specific case, just in the division of the pericallosal and the callosomarginal, this aberrant branch was starting. So that was the to identify that one for me. And if you go to our anatomy, you can see obviously in different patients, different people, we will have these anatomical variations, but you are dealing with your patient, which is fixed anatomy. But I do agree that neuronavigation could be very useful in this kind of cases. But you can see perfectly replicated the anatomy and the angiography. So you have this division between the callosomarginal and pericallosal. This is the aberrant artery going lateral to the head of the caudate. That's the flow aneurysm. And this is the PH vein draining into the internal cerebral vein right here, which is this anatomy we have here. Just the same. Just the same.
Beautiful.
Perfect.
Excellent.
So let's move very fast to the next one, which is a nice history. And this was Sunday. It was 2015 Sunday lunchtime. I was cooking at home and I was on call. And I have a colleague who was on duty in the hospital. And he called me because he had accepted a young guy who was sailing and he fell down from the boat. And you know, they have this kind of needles that they use as flags. So he fell over into a big needle. He was GCS 15 at admission when he came to the hospital, and he was feeling some numbness in the right hemiface. And this is what I found when I arrived to the hospital. And the kid was intubated to do the procedure, and that's the finding. So I would like to ask someone to tell me, I can tell you this needle went inside through a natural corridor in the skull base. So it wasn't a fracture.
So
Which one?
It's the foramen that we generally hit or try to hit.
Yeah, I was planning to hire this guy because I'm terrible with this Moulin technique. It was very good. So which I was concerned that there was no bleeding, but there is an artery. I mean, you can just take it out, but there are two important arteries. One is intracranial, the other one is extracranial, that could be affected and compressed by the needle, but if you take it out, maybe you could cause a bleeding. So that's the question. One is extracranial and one intracranial.
Okay, we have Devi. Mohana, where are you from, please? If we are unmuting you, please answer the question.
Yes, good evening. I am from New Delhi. So this needle seems to be passing by one of these anterior skull base foramens, probably the foramen rotundum, and also maybe by the side of the cavernous sinus. Maybe the hemifacial involvement might be due to the involvement of the fifth nerve. So that is what I would like to.
So which foramen you're thinking about? Fifth nerve?
Foramen rotundum, maxillary.
Well, indeed, it was the foramen ovale.
Not very.
Look attention at the direction. Look at the direction of the needle. Foramen ovale should have gone in this direction, a little bit more parallel to the skull. But that was truth that the needle damaged the fifth nerve. So this is why he was feeling this numbness probably. And which artery could have damaged this needle before going inside the foramen ovale? There is a big artery there.
Intramaxillary.
Yeah, that's the one. So in the pterygopalatine and infratemporal fossa, we have the internal maxillary artery. So that's, in some cases, it's huge artery. In fact, we have a friend who is using that for bypasses. Professor Salim Abdul Rauf is using that one for bypasses, intracranial bypasses. So it must be a high flow one. So, and intracranially, can you see where the needle is located in the CT scan? Very close to the tentorial edge. So which artery is wrapping around the midbrain?
Both PCA and superior cerebellar.
That's it. So I was having some concerns about
PCA.
arteries. So this is the anatomy you perfectly described. So that was the, Gasserian ganglion, V1, V2, V3. You see V3 is going through the foramen ovale, which follows a much more tangential direction. Foramen ovale is almost a parallel direction to the floor of the middle fossa. So that's why I was thinking that it was crossing the foramen ovale. So this is the fifth nerve, V3, and these are the two arteries I was worried about. SCA and PCA, as Vladimir perfectly described, is very, very close to them. So if we do the dissection, we can understand much better.
Does the guy have third nerve palsy?
No, he cannot.
Fourth?
Nothing, absolutely nothing. He was completely intact, only saying me, I have some numbness because of the needle.
Lucky guy.
That's the anatomy of the skull base. So it was crossing this huge foramen. And this is dissection. So try to orient yourselves. I have drilled the floor of the middle fossa from lateral. So this is the infratemporal fossa, this is external carotid artery, and this is the internal maxillary artery. So you can see how big it is. And this is the V3 with the two branches going downward. So the needle crossed the foramen ovale very close to this one and entered the intracranial space. So these are the two important vessels. And next question, how would you manage, how would you fix this situation?
Okay, any takers for management?
Take it
Please
out.
raise your hands. You can pull it out if you want, but please raise your hands. What are you thinking?
So
would you take it out just like that? Or are you going to do an angiogram?
Paravat Kumar, raise hand.
Okay.
Can you figure it out, Salman? So we have him.
Hello. Hello.
Yes, Parvat.
Yeah. After CT cerebral angio, we are confirming that is that near to any vessel or not. Then after we are pull it out.
So angiography.
Yeah.
So this is what we did, and we had a discussion with our colleagues in the radiology department. So what they did, they saw that the internal maxillary artery had some disturbances on its wall. So they placed a balloon exactly here before removing the needle, and another balloon just in case at the level of the right side P1 intracranially. So we had two balloons, and I was taking out the needle progressively while they were injecting a little bit of contrast. So we checked, you see the P2, how close it was to it, but P2 didn't bleed. But once we took it out from the internal maxillary artery, the mouth was open, so I could perfectly see how the needle went out, and we started having a huge bleeding, but they just opened the balloon and the bleeding luckily stopped. So this is how we manage that situation. And that's it, Salman.
What force did you need to use?
Say again?
How difficult was it to remove it?
It was quite easy. I use a guncher.
Hmm?
At the beginning, it was hard, but once it started going out, it was quite easy. But with a guncher all the time.
Yeah. I was once removing a knife, and it was extremely
very nice case. Pablo, really enjoyed both the cases. I think we are going to go on to the multiple choice questions.
Okay.
Just one question, Salman. Hi, Pablo.
Sure.
Was there a CSF leak?
There was not. That's another important concern about this case. There was not. And we just compressed it, and I stitched with two small resorbable stitches, and it was fixed. We were lucky with that. Yeah, but that's very important.
That's very good then.
Well, we do have
Lucky.
the infratemporal fossa and only one needle, so we were not expecting to have a high flow one in case.
Hello, Pablo.
Hello.
Hello, how are you? This is Victor from Mexico City.
Hey, Victor. How are you?
Hey, Victor. Good to have you.
Hi, all of you. I'm very happy to see these interesting cases. So I think the most terrible consequence of this accident is infection. Obviously, you have to make a therapeutic anti to protect potential infection.
Well, we thank you, Victor, for your question. I didn't mention that, but we used for 7 days antibiotics, intravenous antibiotics, and he never had fever. We did 2 MRIs, and there was absolutely nothing there, just a small signal on the T2 and the flare, but almost completely disappeared after 6 months. In the 6 months follow-up MRI I did, and we continue 1 week more. I was also very, very concerned about that, 1 week more with oral antibiotics when he was discharged.
Was very interesting case. Thank you, Pablo.
Pablo, you have to take it away from here. You have to ask questions, and then maybe we go directly to the answers because they're a simple question as far as I can see. Okay, so 125 people fill these forms. So let's go down. Yes, Pablo, all yours.
So sorry, can you say again? I don't know what I have to do.
You have to read the question and tell us that is people gave the right answer or wrong answer or what.
Okay, so first one is most common site of aneurysm is ACA, MCA, ACOM, PCOM, and 60% of you are right, I guess. ACOM is the most common one. Most common organism, microorganism associated with a mycotic aneurysm, Staph aureus, Streptococcus klebsiella, Viridans pseudomonas, and again, I guess most of you are right, 50% with Staphylococcus aureus. These are not my questions, so please apologize me if I'm failing the answers, okay? 45 years old, male presented with sudden onset. Who is the owner of these questions? He should read them.
I have no idea. It should be one of my residents or somebody. I don't know.
Okay, so presented with sudden onset headache and vomiting. CT scan shows subarachnoid hemorrhage. On examination, patient has right-sided third nerve palsy. What is the most likely site of aneurysm? And I guess you are fully right. PCOM is the most common, and probably PCOM pointing downwards, is it? Third cranial nerve palsy, because those ones who are pointing upwards, some of them could cause a subdural hematoma. That's right? I'm asking you?
Yeah, you're right.
This is what I read somewhere. So which is the most common indication for coiling of aneurysm? So calcified aneurysm, ruptured aneurysm, high dome neck rate, or mycotic aneurysm. So
it's
most
actually
of them,
high ratio, yeah. High dome neck ratio, yeah.
That's it. Well, ruptured aneurysm is something that it's depending. So 46 years old male presented with sudden onset headache. CT scan is showing subarachnoid hemorrhage with blood, predominantly in the sylvian fissure. What is the possible site of aneurysm? Well, so the possible site of aneurysm is any of these ones, but the most common one should be MCA. I do agree with that.
I think what happened was we had some difficult questions in a session by Victor recently. And because of that, I asked my residents to just tailor it down a little, and they have gone to very, very simple questions.
They were very good.
Mahak, do you know what we are doing in next couple of days?
Yes, sir. Yes, sir. I'll just show that.
Okay. Oh, we have the roton neuroanatomy session starting. So the module 2 is going to be starting. We did module 1 with ventricles, Chandrasekhar Devpujari, Pablo, Hassan, and Azam were very kind to help with all those. So this one is a special one that Pablo is presenting. It's on phylogenetic evolution of brain. So it's the first session. So we plan to have 4 sessions, I've been told. And this is the first part. So we're doing cerebrum module. And everybody is most welcome. So we would love it if, Victor and Vlad could join us as well and teach us a few tricks. It's going to be fun.
Thank you.
Thank you.
So I think we have this, we have this on, is it Wednesday? Mehak? Pablo should know. Is this Wednesday?
I hope so.
This is on Wednesday, 6 p.m.
And I think then we have, what do we have after that? We have Mike Steinmetz and Liliana Angelov from Cleveland talking about, I think, robotic surgery and something.
And then we have the endoscopy session on Saturday.
Yeah, and then we have IFNE, WFNS endoscopy course on Saturday. And Pujari, you're going to tell us what we are doing on Saturday?
Yeah, you know, Shlomi and Abhay are talking, so I'll be there.
Okay, so if we see here, we have the module on. So firstly, we have this, and on Friday we have Sanjeeva from Oxford and Chan Rosa from MD Anderson. I think they're going to be talking about skull-based approaches. I think Chan Rosa probably is going to do endoscopic tumor excision, and Sanjeeva is going to tell us basic skull-based approaches. And then we have ETV with Shlomi, and we have Chandra. Who else is there? I'm sorry, in the ETV sessions on Saturday.
So it's an IFNE session.
Yeah, but it's Tonex, Shlomi, and somebody else. I can't remember. And then we have module 2 on Sunday. Again, the same group are going to go up with cerebrum. And then we have other sessions that we have discussed. Franco Cervidi is actually giving a talk on management of traumatic brain injury. That's on Wednesday the 10th, and along with Tariq Khan. We are probably going to have a session in which we will honor all the speakers that have come with Franco, and we'll try to organize that and we'll let you know in a day. So we have some stuff going on later on, so we'll keep you posted. Thank you, everybody. It's a pleasure having you all. Any comments? Everybody happy? Thank you, Pablo. That was wonderful. Chandra, Victor, as always. Pablo, brilliant. And
thanks,
Vlad.
Salman.
Oh, this is we have it here. So we have Kulkarni, Antonic, and Shlomi, and we have different versions of ETV and CPC, ETV in infants, and difficult perforation ETV. So I think we have 3. I think probably these 2 topics have been swapped. As far as I remember, Shlomi was going to be talking about in infants, and perforation was a talk by Tanak, but I'll double check that. So thank you, everybody. This was always a pleasure. And Moody is the moderator in that session. So thank you all, dear friends.